Alright guys, as per the poll that I had conducted in my Telegram channel, so most of you students had voted for central retinal arterial occlusion. So in next 15-20 minutes, we are quickly going to revise all the important points of central retinal arterial occlusion. So now, since you know that there is central retinal artery which is entering into the eye and there is central retinal vein which is exiting the eye. So if I make a very short and cute diagram, so this is your optic nerve head. So optic nerve head has got peripheral neuroretinal rim and the central cup. From this cup there is coming in of central retinal artery which gives 4 branches. So this is your superotemporal branch, superonasal branch, inferotemporal branch, inferonasal branch, and side by side there is also exit of the same branches, superotemporal, inferotemporal, superonasal, inferonasal of central retinal vein, right? Okay, now when there is entire occlusion of the central retinal artery, so you call it as central retinal arterial occlusion. But in some cases there may be just an occlusion of a branch of central retinal artery, then you call it as BRAO, branch retinal arterial occlusion. Now which is the most common site of the occlusion of central retinal artery? So most common site, this is also your previous year question, it is just posterior to lamina cribrosa. Now lamina cribrosa, boys and girls, is a place where there is entering of the central retinal artery into the eyeball. So that is your one important PYQ. Okay, now what is the cause of occlusion of central retinal artery? That is actually the plague. Which plague? There is Hollenhorst plague, typical cholesterol plague, that actually tells you that if the patient is having hypercholesterolemia, if the patient is having high blood cholesterol level, the patient is predisposed to central retinal arterial occlusion, which acts as an embolus which gets stuck and causes the entire blocking of the central retinal artery. Yes, here I have also mentioned, I am just going to highlight this. Okay, now when the central retinal artery occlusion has happened, so how the patient is going to come to you, how the patient is going to present it? So there are two things that I want to tell you here. One is central retinal arterial occlusion, another is central retinal vein occlusion. Now if the patient is having central retinal arterial occlusion, will be sudden switching off of light. The patient will have a feeling like I was in a room and there is sudden switching off of light from one eye. तो patient एक आंख बंद करेंगे, ऐसे लगेंगे बिल्कुल अंधेरा हो गया है. But if the patient is having central retinal vein occlusion, so the patient will come to you and will give you a history that I was sitting in a room and I felt as if there is sudden drop of voltage in the room. So that is how you differentiate based on the history. Yes, so of course, because I always say that retina does not have pain fibers, so there will be first and foremost sudden, painful or painless, I want all of you to actively participate. It will be sudden painless loss of vision and the patient will give you a history of sudden switching off of light. समझ आया? Yes, sudden switching off of light. Okay, now when there is complete obliteration of the blood flow of the retina, so there will be RAPD. Why there will be RAPD? You remember the light reflects. So when you shine the light in one eye, the light goes to retina, from where it goes to optic nerve, from where it goes to optic chiasma, from where it goes to optic tract, from where it goes to pretectal nucleus of midbrain, from where there are internuncial fibers which supply to Edinger-Westphal nucleus, which is the nucleus of, my dear boys and girls, third cranial nerve, which passes through the ciliary ganglion and ultimately it supplies sphincter pupillae, and that is how the light reflex is completed. So there is afferent pathway which is your optic nerve, there is efferent pathway which is your oculomotor nerve. But when the retinal blood supply has been blocked, the retina becomes non-receptive. So when you shine the light in the patient's eye, so it is not responding to light, so the pupil will remain dilated. But when you will shift the light from the right eye to the normal eye, you will see that both pupil will constrict. Again you will shift the light onto the abnormal eye, again the pupil will dilate, then again you will shift the light to the normal eye, the pupil will again constrict, so it will be swinging flash light test. So this is one thing, hai na? But RAPD, relative afferent pupillary defect. Why? Because there is damage to the afferent pathway. Not actually damage, it is actually the afferent pathway is non-receptive due to non-receptive retina itself. So RAPD will be there. Now when the blood supply is completely obliterated, all the vessels, superiotemporal and further branches, superionasal and further branches, inferiotemporal, inferionasal. So the blood inside these vessels will form columns, like you sip a soft drink with a straw. The moment you stop sipping, you see small columns of the soft drink, the small columns of cola that you see in the straw. Similarly, you will see small blood columns in the branches of central retinal artery. Those small columns will give you an appearance of cattle truck. So you call it as cattle truck or cattle track. Yes, so cattle track appearance is seen, and of course due to obliteration of blood supply, the fundus will become, fundus means retina, will become pale or milky white. Now normally what happens, fovea has got how many layers, if you could recall? So fovea has got nearly 6 layers. Yes, so fovea is relatively thin. So what you see is normally there is the appearance of the red dot at fovea. Mind you, I am saying normally, that is because of the choroidal blood circulation. Yes, but we are not able to appreciate it normally because the surrounding retina is red, so we are not able to appreciate that small dot at the fovea. But when there is complete obliteration of blood supply of the retina, so this entire retina has become pale. Now this small dot at the fovea, it stands out, so it gives you an appearance of cherry red spot. So cherry red spot at the fovea centralis is seen, like you see here. Can you appreciate? Can you also appreciate, boys and girls? This is pale or milky white retina, and the vessels are going to get thready in due course of time. तो जो vessels हैं वो आने वाले समय में बहुत ज़्यादा thready, बहुत ज़्यादा thin हो जाएगी. Now since we are talking of cherry red spot, I want to cover your one important PYQ. Yes, and it was asked in your FMG examination as well. So what are the causes of cherry red spot? So I am going to tell you differential diagnosis of cherry red spot. So first we are already done CRAO. Then we have got Tay-Sachs disease. Then we have got Niemann-Pick disease. Yes, Niemann-Pick disease. Then Gaucher disease and GM1 gangliosidosis. Then we have got trauma. Trauma is when there is blunt trauma, it leads to the pale or milky white retina around the fovea, and that fovea, that red dot, it stands out. You also call it as Berlin's edema. Yes, and then we have got Sandoff disease. Now there was a question, in which of the following cherry red spot is not seen? And the options were CRAO, Tay-Sachs disease, GM1 gangliosidosis, Gaucher disease. Now in this case, you are going to mark GM1 gangliosidosis. Yes, because here there is not true cherry red spot. Of course, it is a little controversial. Some books mention that in Gaucher disease there is pseudo cherry red spot which you have to pick. Some books say that GM1 gangliosidosis, Yanov, which is a Bible of ophthalmology, it mentions that GM1 gangliosidosis has a pseudo cherry red spot, while GM2 gangliosidosis has true cherry red spot. So here the answer will be GM1 gangliosidosis. This was asked in your recent exam this year only, pseudo cherry red spot. Yes, okay. Now so the universe has blessed with one magical vessel. What is that magical vessel? Now please understand. Now I am first going to mark the features which I have told you. Can you appreciate cherry red spot? Yes or no? Give me thumbs up. Yes, wonderful. Can you appreciate small breaks in the column in the vessels. Can you appreciate here? So this is what, this is your cattle track appearance that I was talking of. But can you also appreciate that this part of retina is viable? Now you say, sir, if there is entire blocking of central retinal artery, how can this part of retina be viable? Because of a magical vessel. The name of that vessel, boys and girls, is cilio-retinal artery, which is actually a branch of short posterior ciliary artery. अब आप बोलोगे सर ये आर्टरी यहाँ क्या कर रही है? ये आर्टरी 35% से 50% लोगों में होती है. This artery is present in nearly 35% of the people normally. Now, if one of those people gets CRAO, now because of the presence of this artery, the fovea remains viable and a part of retina also remains viable, because this is an extra supply, an extra gift to that person from the universe. So cilio-retinal artery, if present, it will maintain the central vision. There will not be complete loss of vision. The central retina, the fovea will remain viable, but that is seen only in nearly 35% of the patients. Yes, here also, can you appreciate? So this is the artery which is supplying the central part. So this is actually cilio-retinal artery. Yes, chalo. Now I want to tell you that central retinal artery is an important image based question. It was asked in your recent FMGE exam. Now since you all know that NAT board takes FMG, NAT board takes NEET PG. So if you are preparing for FMG, you have to go for NEET PG questions. If you are preparing for NEET PG, you have to go for FMG question. If you are going on for INI-CT, means primary target INI-CT, you have to do FMG, NEET PG as well. Yes. Okay. And for NEET PG also you have to touch INI-CT. But for FMG, you don't have to go for INI-CT. Just focus on FMG PYQs last 3 years and NEET PG PYQs last 3 years. Okay, now coming over to the management in this patient. Yes, now the patient has come to me. Now I am scared. The patient is saying I am not able to see anything. I examined the retina. The retina is pale and milky white. First is, what is retinal ischemic time? Retinal ischemic time is the time for which the retina can bear ischemia. Yes, ischemia means after this time the retinal cells start to die. It is 90 minutes. Now what is the maximum time after which no retina will be viable? कौन सा कितना वो समय है? तो पहले 90 मिनट जो होंगे वो इस्कीमिया होगा. अभी अगर इस 90 मिनट में आपने रीस्टोर कर दी ब्लड सप्लाई तो नॉट इवन अ सिंगल सेल विल डाई. इसका मतलब तो ये हुआ ना. बट मैक्सिमम टाइम कितना है जिसमें आप रेटिना के कुछ सेल्स को बचा पाओगे? तो मैक्सिमम टाइम इज 12 आवर्स. इफ यू स्टार्ट योर ट्रीटमेंट आफ्टर 12 आवर्स, not even a single retina cell will remain viable. Yes, so the vision loss will be profused. Okay, now the patient has come to me. What will be the first and foremost thing which I am going to do? I am going to do ocular massage, massaging the eyeball. Ask the patient to close the eye, then do ocular massage. Massaging the eyeball sometimes may dislodge the embolus. First. Second is you give IV mannitol, intravenous mannitol. Now mannitol is hyperosmotic agent which starts acting in as less as 20 minutes. So what you are doing is, so there is central retinal artery which is taking the blood to the eyeball. There is a counter pressure by the intraocular pressure. Yes, and when you not suddenly actually, by giving mannitol, when you decrease the counter pressure, so there is gush of blood in the central retinal artery which may dislodge the clot. That is the point, that is the concept here. So you can give IV mannitol. Yes, now you'll say, sir, why not other IOP lowering drugs? Because IV mannitol starts acting in just 20 minutes and it acts by, can you tell me the mechanism of action? We use it in glaucoma only, acute attack of angle closure glaucoma. its mechanism of action is it decreases the bulk of vitreous, it extracts water from the vitreous humor, है ना? Okay, now if it is not effective, the third is you simply take a small syringe with a needle, you put the needle in the anterior chamber, suck the aqueous humor. This is even more immediate than giving mannitol. So it will suddenly decrease the counter pressure, and that means suddenly dislodge the blood, dislodge the embolus in the blood vessel. Third, but fourth step, so I am going very stepwise, but the fourth step is, if it is not cured, if it is not treated, if the embolus is not dislodged, you will go on for giving carbogen inhalation. Carbogen inhalation is you give 95% oxygen, 5% CO2. It may lead to dilatation of the vessels and may restore blood supply. And fifth and last is you go for IV TPA, tissue plasminogen activator. But if I am sitting in my OPD and the patient has come, so what I am going to do? So I am of course going to try the one method out of these five, which is the best. Which is the best method? Best method is paracentesis, because it is suddenly leading to decrease in the intraocular pressure. Yes, so this is your best. This is also your previous year question. And now I am going to give you 2 important points. One is, have you ever heard of something known as ERG? ERG is electroretinogram. This is one extra point. If you are aiming for INI-CT, for FMG you don't need to go through it. Electroretinogram. So there is electroretinogram in which we look out for 3 waves: A wave, B wave and C wave in central retinal arterial occlusion. So B wave is abnormal, important with respect to INI-CT. B wave is abnormal in electroretinogram in CRAO. You know that there is another technique which is electrooculogram. As I will be posting more videos covering more and more topics, I'll be telling about ERG, EOG, all of it, so don't worry. So recently I had done a video on retinitis pigmentosa where I have already told about ERG, so you can go through it if you want to know more about ERG. Okay, so yes, and as I always say, one is I just teach you the theory, another is I give you an orientation, hai na? So if you are in my class, you will actually see the real patient based videos. So I am going to show you now CRAO. Check out CRAO. So this is with the help of a mobile and lens by which I have focused on the retina. Now can you appreciate that there is presence of cherry red spot? There is another important thing which we have just discussed. If you could appreciate, you just need to WhatsApp me and tell me what else do you see. So here in this patient, can you appreciate cherry red spot and there is milky white retina? I hope you are able to appreciate it. देख पा रहे हैं आराम से, है ना? देखो, ध्यान से देखो. So the retina is pale and milky white. But यहाँ पे एक important चीज और आपको दिख रही है. ध्यान से देखना इस वीडियो को. कुछ एक्स्ट्रा चीज आप जरूर पकड़ पाओगे. आप बोलोगे सर चेरी रेड स्पॉट तो है ही है, बट एक चीज और है. वो क्या है? क्या आप मुझे वो बता पाएंगे? कहाँ पे बताएंगे? आई एम शेयरिंग माई व्हाट्सएप नंबर. सो यू नीड टू टेल मी व्हाट दैट एक्स्ट्रा थिंग दैट यू could appreciate in this video. And my name is, नाम तो पता ही होगा, राज. No, not Raj, Dr. Manish. So as always, it is my pleasure to come online and by the way of videos interact with you. And in case of any doubts, any queries, you can get back to me anytime. Best wishes from my side.